My clinical pattern presentation is on hip labral repairs, which are surgical procedures involving either the debridement, repair, or replacing of the acetabular labrum of the hip. Surgery is usually not indicated until after a conservative approach, such as physical therapy, has been attempted for the pre-existing labral tear. And then surgery might also address an underlying condition such as femoral acetabular impingement if that's applicable to the patient. It's important to note that not all hip labral tears warrant surgery. There's going to be another clinical presentation on treating just a tear that has not undergone surgery for repair. So some of the patient demographics. The age range of common patients who undergo this surgery is really wide, going from 8 to 72 years old, but it is most common in women and women in their 40s. It's also important to note that athletes are at high risk, especially depending on the nature of their sport. We'll talk a little bit more of the mechanism of injuries that can relate to that. The two most common outcome tools that are used for this injury are the lower extremity functional scale and the hip outcome score. So the original mechanism of injury that is indicated for a hip labral repair is, of course, the initial hip labral tear, which those can be caused by trauma, repetitive motions, or just degenerative effects with aging. Structural abnormalities or hip interarticular pathologies can also cause the initial tear. And then those repetitive motions that I mentioned usually will include some type of sudden twisting, cutting, or pivoting, which again, like I said, is common in athletes. We're not going to really see any aggravating or easing factors, nor will there be a 24-hour typical pattern for post-surgical patients. And then in regards to if you need to do a full systems review or review of systems for a patient, use your discretion on that because you have a diagnosis and you have a surgical procedure that was done, but it's also a good idea to have an understanding of a patient's overall health status. So in regards to precautions and contraindications, that's going to be really big to talk about for hip labral repairs because your exam is going to be extremely limited, both with weight bearing and range of motion limitations. It's important to note that when you have a new patient coming in that's had this type of surgery, make sure you consult the surgical report so that you know exactly what happened while they were in surgery. Patients are going to have partial weight bearing status for at least 3 to 6 weeks post-surgery. By week 8 is when we should see patients be able to go down to the use of just one crutch, or if they're able to ambulate without an assistive device, that's great. And then in regards to range of motion, for the first 3 weeks, the following limitations are in effect. No hip flexion past 90 degrees, no hip extension past neutral, no hip abduction over 30 degrees, and then hip internal and external rotation needs to be limited between 0 to 30 degrees. Full range of motion should be achieved by about 12 weeks post-op, or at least by that stage of rehabilitation, the patient should be working towards achieving full range of motion as tolerated. You will see in my written clinical pattern, that I have made charts of timelines of what to expect for weight-bearing status that goes from 0 to 8 weeks post-op, and as well as the same thing for range of motion that actually goes from 0 to 12 weeks post-op. So I encourage you to check those out. There are 2 really popular treatment protocols to follow for physical therapy rehab. One of them is the Brigham and Women's Hospital protocol and the University of Wisconsin. Some common themes that are in those is no active straight leg raise throughout rehab and avoid pain and pinching in the anterior hip. And then plyometrics or sport specific training, we cannot start doing that until after week 16 after surgery. With the physical examination, you can expect some pain, some inflammation. Numbness is normal in that anterior hip region after patients usually will have a nerve block with this type of surgery. With both active range of motion and passive range of motion, you have to follow the range of motion protocols and limitations and make sure you're not exceeding that. And then resisted testing is not applicable. You're not going to do any neurodynamics or any special tests on patients that have had this surgery. And then with accessory motion, this was very interesting to me. Grades 1 and 2 for joint mobilizations might be appropriate for pain relief. Make sure you check with the surgeon prior to doing that. Grades 3 and 4 and long axis hip distraction are contraindicated until after week 8. Diagnostic imaging that is used is prior to surgery, MRI, and then an arthroscope are used to diagnose the initial tear. And then some signs and symptoms that you need to refer the patient back to the physician include general signs of infection, signs of a DVT, and then especially if you feel like a patient is not progressing at the timeline that they should according to the rehab protocol, make sure you send them back to their surgeon. Thank you.